All right, good morning. We're going to learn about burns today. So we're in chapter 21. All right, so I'm going to share the PowerPoint. Don't pay attention to the chapter on there. It's chapter 21, I believe. So it talks about burns. It says they range in severity from minor sunburns to life-threatening trauma. A burn is an injury to the tissue caused by either a chemical, an electrical, radiation, inhalation, or thermal burn. The changes from a burn, anatomical changes, remember that the skin can regrow as long as parts of the dermis are present. When the entire dermal layer is burned, all cells and the dermal appendages are destroyed and the skin can no longer restore itself. So then they're going to need a graft. As far as functional changes are going to be altered tissue integrity. So we're going to have to protect them from infection. They're also going to have sensory deficits and fluid balance deficits because of excessive evaporation caused by that burn. Psychosocial changes, you've got body image to think about, how it's going to affect them. This could lead to depression. It could also lead to anxiety or condition PTSD, post-traumatic stress disorder. There's also vascular changes to consider. It's going to cause constriction of the vessels, which can cause thrombosis, and it's also going to cause edema. In the cardiac system, they're going to have an increased heart rate and a decreased cardiac output. So this is going to affect tissue perfusion. In the pulmonary system or the lungs, they're going to have airway edema caused by sloughing of the lining of the lungs, and this could lead to obstruction. In the GI system, they're going to have decreased mucosal tissue integrity, and this is going to decrease motility and cause abdominal distension and possible ulcers. Ulcers is a very big thing with burns. That's why they have to have a proton pump inhibitor prescribed or an H2 receptor antagonist to minimize that acid. There's also metabolic changes, increased metabolism, increased catecholamine, so the adrenaline, the epi, the norepinephrine, increased antidiuretic hormone, increased aldosterone, which is going to cause increased sodium reabsorption, and increased cortisol. In the immune system, they're going to have increased inflammation, which is also going to put them at increased risk for infection. So these are all the things that we have to consider. When we're talking about the extent of the burn injury, the burn classification, depth of destruction, and the degree of burn degree thickness, the severity of a burn is determined by how much of the body surface area is involved. The quickest method for calculating the size of a burn injury um, in an adult will take the weight are the normal proportions to their height. This is the rule of nines, the weight in proportion to height. There are two primary systems to classify them. The first one is the degree of burn. So you got a first degree burn where there's epidermal damage. They will have pain, but there's no eschar, no necrotic tissue. A second degree burn will also cause dermal damage. Most people will still have pain and blistering, but again, no eschar. A third degree burn, which is a full thickness burn, goes all the way into the subcutaneous tissue. They will have little to no pain, and there will be eschar or necrotic tissue present. With the fourth degree burn, there's damage into the muscle tendon, and the bone, they will not have any pain because they've fried the nerves, and they will have hard, inelastic eschar, which could be dangerous. This could cause a circumferential burn, which could put pressure on vessels and nerves and organs. So they usually would have to have an escharotomy, which is where they take incisions and take the pressure off of that tissue. They also rate burns by the degree of thickness. So you have superficial, which is above the basal layer of the epidermis. The burn's going to appear dry, pink, or red. You also have a superficial second, partial, which goes into the dermal layer. This will present as moist red, but it will blanch and blister. Then you have the deep second, deeper into the dermis. It'll be slightly moist and may need a graft. Then you have the full thickness, the entire skin thickness into the subcutaneous. The tissue can be any color, and this will require grafting as well. The muscle, tendon, and bone tissues appears black and requires graft repair. All right, then they've got this diagram here breaking down the rule of nines. This is also known as the Wallace rule of nines. It's a tool utilized by medical providers to assess the total body surface area involved in burn patients. So we use that Parkland burn formula to estimate the amount of fluid needed for burn resuscitation in the first 24 hours after a burn injury. The Parkland burn formula is 4 mLs times weight in kilogram times total body surface area burn. Once we get this amount, we will divide it in half, and the first 8 hours, they will receive half of the total calculated fluid volume. The remaining half is given over the next 16 hours. So you have to learn those percentages. All right, so then it talks about the pathophysiology of an uncomplicated burn. It says you have different types. For the chemical, the severity of the injury depends on the duration of contact, the concentration of the chemical, the amount of tissue exposed, and the chemical's action, whether it's an acid or an alkaline, which are the most common. For the electrical burn, the true electrical injury occurs when electrical currents enter the body. These injuries are described as having what's called an iceberg effect because the surface injuries may look small, but the associated internal injuries can be significant. Once the current penetrates the skin, it causes an entry wound and it flows through the body and damages the tissue until it leaves the body at the exit wound. Then you have a radiation burn. Radiation burns occur with prolonged exposure to the sun or to sources such as X-rays or radiation treatment. You also have smoke-related burn injuries occur on inhalation. Oral facial burns can cause edema that impairs breathing. Now, you got to know this. Even if you believe the patient experienced only a minor burn, it is critical to assess the mouth, the throat, and nose for signs of soot. Listen for coughing, shortness of breath, hoarseness of the voice, or difficulty swallowing, which may indicate a smoke inhalation burn. Very important. For the thermal burns, these are caused by contact with flames, such as dry heat burns or hot liquids, which is moist heat, or scald burns. Also, hot objects or substances that can cause contact burns. Dry heat injuries are caused by open flame and explosions. Explosions usually result in flash burns because they produce a brief exposure to very high temperature. The moist heat or the scald injuries are caused by contact with hot liquids or steam and are common among older adults. Hot liquid spills usually burn the chest or the arms, and immersion scald injuries usually involve the legs. Then you have the contact burns. These occur from hot metal, tar, or grease and often lead to a full thickness injury. Tar and asphalt temperatures usually are greater than 400 degrees Fahrenheit, and deep injuries occur within seconds. Hot grease injuries from cooking are usually deep because of the high temperature. Okay, and then it just shows this chart here. The difference between the superficial thickness, the superficial partial thickness, the deep partial versus full and deep full thickness. So you got to know the presentations. We've already talked about most of these. Okay. All right. So then we move down to the health promotion and maintenance to prevent the prevention. Okay. It says here use the home smoke and carbon monoxide detectors, fire extinguishers. So we got to know our fire extinguisher types. Fire extinguisher, A. We got to know A for ash. Anything that burns and makes ash. Paper, plastic, wood, cardboard. Then the class Bs, anything that boils. So kerosene, gasoline, grease. The class C, which is for our electrical fires. So current. Class D for our difficult metals, and our class K for our kitchen fires. We also must remember two very important acronyms. The first is called RACE. So this is what we're going to do in the event of a fire. We're going to rescue the patient if possible, and then we're going to activate the alarm. Then we're going to try to contain the fire by closing the doors of the windows, and then extinguish or escape, depending on if we have the opportunity to extinguish. We also need to remember the acronym PASS. Teaches us how to use the fire extinguisher. So we're going to pull the pin on the fire extinguisher and aim at the base of the fire, and then squeeze the trigger and sweep side to side. Now, on this slide, there's a very important thing here. We shouldn't keep that water heater, the temperature no higher than 120. Any water, we don't want to burn someone. And turn those pots inward, especially for the children. Very important to remember. All right, so the next thing we got to talk about is the burn phases. These are the three phases of burn management. As you can see, the first one is called emergent or resuscitative. The second is acute or healing. And the third is rehabilitative or restorative. The emergent phase of a burn injury begins at the onset of injury, and it continues for about 24 to 48 hours. During this phase, the injury is evaluated and priorities of care are determined based on the extent and severity of the burn. The priorities of care during the emergent phase include securing the airway, supporting circulation and perfusion, maintaining body temperature, keeping the patient comfortable with analgesics, and providing emotional support. The second phase, the acute or healing phase of a burn injury, begins about 36 to 48 hours after injury when the fluid shift resolves and lasts until wound closure is complete. During this phase, the nurse coordinates interprofessional care that is directed towards continued assessment and maintenance of the cardiovascular and respiratory systems, as well as nutritional status. Burn wound care needs to be done to preserve that tissue integrity. We also need to help control pain and have some psychosocial interventions in place because there's a big time risk for pneumonia. The technical rehabilitative or restorative phase, this begins with wound closure and ends when the patient achieves his or her highest level of functioning. And they need this psychosocial adjustment. All right, so then it talks about the burn injury assessment. We need to obtain information regarding the circumstances surrounding the burn injury, the age, weight, height, full health history, allergies. To minimize the risk of infection, the patient may be placed in a private room even before the history is taken. We get into directly from the patient or witness what, when, where, and what care was given before admission. Care in the first hour after a burn can actually prevent death. Okay. All right, so it talks about the assessment. We have to assess that respiratory system. Even a small change can indicate pulmonary injury. So we need to be assessing for drooling, difficulty swallowing, change in pattern, voice patterns, hoarseness, any type of cough, wheeze, or even stridor, which indicates that upper airway obstruction. A sudden disappearance of wheezing can also indicate obstruction, and they would require immediate intubation. Now, carbon monoxide poisoning. They can present with carbon monoxide poisoning, which usually causes a headache, confusion, flushing of the skin, tachypnea followed by bradypnea, so fast respiratory rate followed by slow. Also, tachycardia followed by bradycardia, fast followed by slow heart rate. The skin will present cherry red, but here's the trick: the PaO2 will appear normal. Okay, so we have to be very careful with this one. Now, cyanide exposure. This is a bitter almond odor to the breath, similar to signs of carbon monoxide poisoning. They can also experience pulmonary fluid overload. If they have pulmonary fluid overload or pulmonary edema, they'll have crackles, shortness of breath, and dyspnea. So, as a part of that assessment, we're going to have to do this, the rule of nines, to determine the total body surface area that's burned. Also, we're going to have to assess the appearance of the burn and measurements of the burn. Now, the labs we want to get are going to be the hemoglobin and hematocrit, which will appear elevated because of the lack of fluid. The urea nitrogen, so the bun, that'll be elevated. The blood sugar, which will also be elevated. Now, electrolytes, sodium is going to be decreased because it's leaked out of the skin, and potassium is going to be elevated because it leaked out of the cells. Chloride will also be elevated, but the protein and the albumin level, however, will be decreased. And the cardiovascular system, like we said, they'll be tachycardic with a low blood pressure. They'll also have edema and decreased peripheral pulses. They'll also have a slow cap refill and the EKG. They may have some type of uh, abnormal dysrhythmia. Um, we also need to do invasive blood pressure monitoring, so hemodynamic monitoring. Um, that's with the Swan scans catheter. In the musculoskeletal system, we have to assess active and passive range of motion and try to prevent contractures. And they may experience a hypermetabolic state after a serious burn. This will cause increased blood pressure, heart rate, peripheral insulin resistance, protein loss, and muscle wasting. Um, uh, so they're going to have, because of the low fluid volume, they're going to have a decreased cardiac output. Oxygen consumption will be higher, and the metabolic rate will be higher, and they'll be hyperglycemic. Starting at 5 days, last until the wound closes, metabolism increases. They'll have hyperdynamic circulation and increased insulin resistance. And the urinary and kidneys, they'll have decreased urinary output, uh, concentrated urine, high specific gravity. Myoglobin will also be elevated. Hemoglobin and uric acid will be present. In the GI system, they may have a paralytic ileus that will cause nausea, vomiting, abdominal distension, and pain. So we have to monitor for a GI bleed because they're also at risk for ulcers. That's why that proton pump inhibitor is so important. All right. So we got the burn injury interventions. So remember, any burn, better know this, of the head, neck, and chest often involves damage to the pulmonary tree due to the heat as well as smoke and soot inhalation. This can result in severe respiratory difficulty. Nursing measures to maintain a patent airway should take priority, assess the patency of the airway, and administer oxygen. As far as the pain, it's determined by individuals. They may need a PCA pump or they may need an alternative therapy. Medicate prior to dressing changes in wound care. If it's mild pain, usually non opioid drugs are given, like NSAIDs and acetaminophen or some topical aloe. If it's severe, then they'll get the opioids. If it's neuropathic pain, then we'll use gabapentin or pregabalin, uh, an anticonvulsant type med. Now, as far as those IV fluids, remember they're going to need IV fluid resuscitation. You have to monitor vitals. Pay attention here. When a client's circulating fluid volume is low, the heart rate increases to maintain adequate blood pressure. Therefore, the nurse should identify a decrease in heart rate as an indicator of adequate fluid replacement. So if they were tachycardic, you started giving them fluid. If that fluid is adequate, you should notice a drop in that heart rate, which is a good thing if they're tachycardic. The rule of nines and Parkland burn formula are used to determine this need. Check for signs and symptoms of local and systemic infection. You may have to obtain a culture for antibiotics. They're going to need fluids. You're going to need to do sterile technique for the dressing changes and teach them to avoid crowds, wash their hands, and they're going to need a tetanus vaccine. Now, for the wound healing, this typically involves three main phases of wound healing. You got the inflammatory stage. This phase is characterized by redness, swelling, and pain as the body's immune system works to fight the infection and remove the debris. Then you have the proliferation stage. The new skin cells and blood vessels are formed to fill in the damaged area. This is also when blisters may form as the body attempts to separate damaged tissue. Then you have what's called remodeling. This is the maturation of the new skin and tissue, as well as the formation of scar tissue. For a first degree burn, it'll heal in about 1 week, whereas a second degree takes about 2 to 6 weeks. A third degree could take 6 weeks to 6 months, and a fourth degree could be greater than 6 months if it heals at all. So the burn treatments, you're going to do debridement, removal of the dead tissue to restore the tissue integrity and prevent infection. Now pay attention. An eschar-otomy. An eschar-otomy is a surgical incision made to release pressure and improve circulation in a part of the body that has a deep burn and is experiencing excessive swelling. Burn injuries that encircle a body part, such as an arm or the chest, can cause swelling and tightness in the affected area, resulting in reduced circulation. Making surgical incisions into the burned tissue allows the skin to expand and reduces tightness and pressure and improves circulation. Also, hydrotherapy is used to assist in the debridement of dead tissue from the burn wound. The client is placed into a shower, and nurses use forceps and scissors to remove tissue. The running water keeps the body temperature consistent and aids in visualization of the wound. We can also do grafting, skin grafting. This is a surgical procedure in which a piece of skin from one area of the body is transplanted to another area, and this is called a skin graft. There are different types of skin grafts. You have autograft, that's the patient's own tissue, and this is the least risk of infection. You have the allograft, the donor tissue from a human, and then you have the xenograft, the donor tissue from a non-human species. And you also have skin substitutes, biological, synthetic, or biosynthetic. All right, so then we move into where it talks about life-threatening skin disorders. So you have what's called Steven Johnson syndrome. This involves skin detachment of less than 10% of the body surface. You also have toxic epidermal necrolysis. Overlap describes patients in whom more than 10% but less than 30% of the body surface is detached. And it says with that toxic epidermal necrolysis, it involves detachment of more than 30% of the body surface. So there's a little picture there of it on slide 13. It's often called flesh-eating disease. It's a severe bacterial infection that spreads rapidly through the soft tissue of the body, causing tissue death, also known as necrosis. It's a life-threatening condition requiring immediate medical attention. The group A, Streptococcus, is common culprit, but other bacteria like Clostridium or Escherichia coli or Staphylococcus aureus can also cause it. Early symptoms can be subtle, like a flu-like illness, severe pain, redness and swelling that can spread rapidly, and a small red painful lump that grows later in the skin. Uh, Skin may become discolored, bluish purple or black, and blisters or ulcers may appear, and the area may ooze fluid. So the treatment here involves immediate hospitalization, IV antibiotics, and often surgery to remove that infected tissue. Necrotizing fasciitis. All right, then we look at this Steven Johnson's syndrome. It's a rare but serious skin reaction that can involve both the skin and mucous membranes. It's a type of severe cutaneous adverse reaction called SCAR or SCAR. It's a life-threatening condition. It's often triggered by a medication reaction, but other causes can be infections or underlying conditions. It's characterized by a skin rash, blisters, and peeling of the skin, along with potential involvement of the mucous membranes like the mouth, the eyes, and the genitals. The drugs most commonly associated with Steven Johnson's or the necrotizing fasciitis include allopurinol, carbamazepine, lamotrigine, phenobarbital, phenytoin, sulfasalazine, and immediate treatment involves withdrawal of the drug. These patients are often cared for in a burn unit because of the serious complications, including dehydration and infection. It can also lead to organ failure and death. Long-term complications can include visual problems, scarring, and changes in skin pigmentation. Okay. And then we move down to the toxic epidermal necrolysis, a rare but severe skin reaction usually triggered by medications, causing blistering, peeling, and potentially life-threatening complication. It's a more severe form of Steven Johnson syndrome. It can lead to infections, organ failure, and death. It begins with a flat red or purple rash that spreads across the body. The blisters form and the skin peels away, often revealing open erosions. And at least 30% of the body surface is typically affected by the skin damage. Other symptoms include fever, cough, runny nose, conjunctivitis, and appetite loss. All right, so that wraps up that first chapter. Give me a second. I'm preparing the second one. All right. So let's bring this down for a second. Pop this out. Back down here. All right, so we got vascular disorders to do as well. Chapter 33. Oh, this is the one I gotta do this with it. All right, hold on. I'm gonna do this. I'm gonna put up the. All right, very good. Let's go over here, share the screen. All right. So again, don't pay attention to the number. You know what chapter we're in. It's the right chapter. All right. So it talks about hypertension. That's the first thing it talks about. Okay. Remember, hypertension, what is it? It's an increased force against the arterial wall due to an increased force of blood. Okay, arterial blood against the arterial wall due to an underlying condition, and that condition could be atherosclerosis, okay, or arteriosclerosis, which is a hardening of the vessels, or it could be from increased blood volume or the thickness of the blood, like the viscosity of the blood. So it says the desired blood pressure for those over 60 should be lower than 150 over 90, and for people younger than 60, below 140 over 90. All right. So here's the actual scale that you got to learn. Okay, this is the scale that they use to determine when you're at high blood pressure. So you got to learn this scale. Okay, and just remember, we do not start medications until they're at stage 2. Before that, we'll just use lifestyle modifications, changing diet, get that exercise, reduce that stress. All right, so then it talks about what mechanisms influence the blood pressure. Well, the systemic arterial blood pressure, or the cardiac output, the stroke volume, and the heart rate. These all influence blood pressure just as well as the preload and the afterload. The arterial baroreceptors are found rather in the carotid sinus. They're found in the aortic arch and the walls of the left ventricle, and they provide this reflex control of circulation, which can elevate the systemic arterial pressure when it falls and lowers it when it rises. Also, fluid volume, excessive sodium or water increases blood pressure. Rise in blood pressure will trigger the renal system to induce diuresis in order to lower the blood pressure. And then you got that RAS system. The kidneys produce renin acts on angiotensinogen to become angiotensin 1. Then that acts on angiotensin converting enzyme to become angiotensin 2. And then angiotensin 2 causes vasoconstriction. This triggers the release of aldosterone, which causes sodium retention. This causes fluid retention, which causes increased blood volume, and that will increase the blood pressure. And then you got another way, the vascular autoregulation. This is an intrinsic ability of the blood vessel to maintain constant blood flow despite changes in blood pressure. It's achieved by changing the diameter. The small arteries that branch into the capillaries, they can constrict to increase the pressure and dilate to slow it. Okay. All right. So then it talks about essential hypertension. Essential hypertension. This is also known as primary hypertension. Um, the risk factors for acquiring this are if you have a family history of hypertension, African American ethnicity, if you have a condition like hyperlipidemia, if you're a smoker, if you're older than 60 years or postmenopausal, if you have excessive sodium and caffeine intake, if you're overweight or obese, if you don't practice an active lifestyle, if you use excessive alcohol, if you have low potassium, calcium, or magnesium intake, or excessive and continuous stress. It can cause medical hyperplasia or thickening of the arterioles, and this will increase the pressure and decrease perfusion. Complications, you can have a MI, a CVA, a vascular disease, or kidney failure. Okay. All right. So then we talk next about secondary hypertension. Um, Secondary hypertension is usually caused by kidney disease, some type of renal artery stenosis. It can also be caused by the adrenal gland if it releases excessive aldosterone or cortisol. It can cause by having a tumor on the adrenal gland called phenochromocystoma. It can be caused by Cushing's disease, where there's the adrenocortical hyperplasia, um, which leads to excessive glucocorticoids, or it could be caused by coarctation of the aorta. That's a narrowing of the aorta, the main artery carrying blood from the heart to the body that occurs at birth. And this can develop later in life due to events like trauma, atherosclerosis, or arteriitis, inflammation of those arteries. All right, so then it talks about hypertensive crisis or malignant hypertension. Um, this is serious. This is a medical emergency. If this happens, you're going to place the patient in a semi-Fowler's position. You're going to administer oxygen, and you're going to administer IV beta blockers or nicardipine or other infusion drugs. When they're stable, then you'll switch them to an oral antihypertensive drug. You're going to monitor the blood pressure every 5 to 15 minutes until the diastolic pressure is below 90 and not less than 75. Then you're going to monitor the blood pressure every 30 minutes to ensure that the blood pressure is not lowered too quickly. You also need to observe for neurological or cardiovascular complications, which include seizures, numbness and weakness of the extremities, a dysrhythmia, or chest pain. These are possible indicators of target organ damage, so we have to be aware of that. All right, so now it's talking about the hypertension regarding the health promotion and prevention. What do we do to prevent or avoid? We got to implement dietary approaches. One of those is that DASH diet, dietary approaches to stop hypertension. This is a diet that is high in fruits and vegetables and low in fat and dairy products. Also, enhance the intake of potassium, calcium, magnesium, and fiber, and lower the sodium. The optimal goal of sodium is less than 1,500 milligrams of sodium per day. That's the stricter version. I think there's the 2,000 is less strict, but the strictest version of this diet would be limiting to 1,500. Also, increase physical activity. That includes aerobic exercise, resistance training, and static isometric exercises. All right, then we go down to the next one here. It says um, assessment. When you're doing your assessment, make sure you get a blood pressure in both arms. Keep a log, teach the patient, keep a log at home to determine if they have this rare condition called white coat syndrome. This is where when they come to the doctor, there's nothing wrong with their blood pressure, but everywhere else it's ridiculously high. Also, we're going to be aware of orthostatic changes. So we're going to do those orthostatic blood pressures. We'll have them um, take their blood pressure while they're laying down, then move to a sitting and wait 3 minutes and obtain that blood pressure, and then move them to a standing position, wait 3 minutes and obtain that blood pressure. Now, they have orthostatic hypotension if they have a decrease in the blood pressure of 20 millimeters of mercury systolic or 10 millimeters of mercury diastolic. Also, assess, listen, better pay attention here. Pay attention. Normal heart tones. When assessing the heart tones, we're listening for S1 and S2. which are the opening and closing of the valves of the heart. The valves of the heart are the aortic, pulmonic, tricuspid, and mitral. The nurse should auscultate the client's apical pulse over the apex of the heart at the anatomical landmark of the fifth intercostal space and below the left nipple line to the left of the sternal border. Got to know that. Now, there's also going to be some retinal changes to the eye, narrowing of the arteries. This causes swelling of the optic nerve, and it can cause bleeding into the retina. These changes can lead to visual problems such as blurry vision, double vision, and severe cases, vision loss. So we have to teach them to get those visual exams. Also, they can have abnormal bruits or salves in the arteries. They can suffer from pheochromocytoma that'll cause tachycardia, sweating, pallor, ash, and gray skin. And from that coarctation of the aorta, they can have elevations in blood pressure in both arms with low blood pressure in the lower extremities. Okay. So when we move into the next slide, the hypertensive assessment, it says for the kidney disease, they're going to have proteins and red blood cells in the urine with an elevated bun and creatinine. Also, the EKG, they'll have left atrial and ventricular hypertrophy and left ventricular remodeling. With the pheochromocytoma, there's going to be the presence of catecholamines in the urine. And with the Cushing's, they'll have elevation of serum corticoids and that 17 keto steroid in the urine, indicators of these conditions. All right, then it talks about arteriosclerosis and atherosclerosis. With the atherosclerosis, that's inflammation that causes the fatty streaks to develop. Cellular proliferation brings collagen to the streaks, and this forms a plaque. The plaques are stable or unstable or prone to rupture, which causes a thrombosis, which can lead to inadequate tissue perfusion. You can see the picture there. A normal artery compared to an artery with a fat buildup or that arteriosclerosis, which eventually blocks that blood flow. All right. So when do we know they have these type of issues? Well, when we do our assessments. When you're checking that cap refill, it'll be greater than 3 in a young to middle-aged adult, or it may be greater than 5 in an older adult. This indicates that poor tissue perfusion. The extremity will also be cold with diminished or absent pulses if it's severe. The bruits heard with the stethoscope or the Doppler indicates turbulent blood flow. It'll make a swishing sound. Okay, so they could have a bruit in the carotid, aortic, femoral, or popliteal arteries. Also, they'll have high HDLs and high LDLs. Remember, the LDLs are the bad cholesterol, the HDLs are the good cholesterol. Right, so then we move into the next slide. Okay, it just talks about interventions. Okay, you guys can read these. Remember, there's certain things that are modifiable, certain things that are non-modifiable. The priority is the non-modifiable ones because you can't change those. All right, so then it mentions drug therapy, the HMG CoA reductase inhibitor. See, that's how you correctly say the statin. You gotta know it that way. The HMG CoA reductase inhibitor. You can't just always call it a statin because they may not be nice in the test question, and they could refer to it as an HMG CoA reductase inhibitor. So, the HMG CoA reductase inhibitor. These are the statin, and most of them end in statin. So atorvastatin, fluvastatin, lovastatin, pitavastatin, pravastatin, rosuvastatin, simvastatin. These all affect hyperlipidemia. Okay, so they're used to treat that familial hypercholesterolemia, um, because you take them because of the risk of coronary heart disease. Also for atherosclerosis, they inhibit the manufacturing of cholesterol or promote the breakdown of cholesterol. That's what these do. Then you've got the fibrinic acids. The fibrinic acids. So fenofibrate, gimfibrazil. These are fibrinic acids. They act by reducing very low density and stimulating the catabolism of triglyceride rich lipoproteins. They also increase the excretion of cholesterol in feces and reduce the production of triglycerides. Mm-hmm. Then you have the bile acid resins. These bind to bile acid to form an insoluble substance that cannot be absorbed by the intestine, so instead it's excreted in the feces. Then you got that PCSK9. These are LDL lowering drugs used for patients who have genetic familial hyperlipidemia or a very high risk of um, coronary vascular disease. The PCSK9 is an enzyme that binds with the LDL and prevents it from being removed from the blood. It blocks the process. And you also have niacin, the vitamin. This can cause vasodilation, so they increase the blood flow. All right. So then it talks about is what does this say? Which assessment finding would the nurse anticipate in a client with severe atherosclerotic disease? Well, it's going to be that carotid artery brute that we talked about. Okay, not that good HDL that they have down there or that palpable pulse or a good blood pressure. It's going to be the problem, the carotid artery brute. All right, then it goes into talking about peripheral arterial disease. So you got these two flavors, arterial or venual. Now it's talking about the arterial. It includes disorders that change the flow of blood through the arteries and the veins of the peripheral circulation, um, causing decreased perfusion to body tissue. It affects the legs much more frequently than the arms. In general, a diagnosis of vascular disease implies arterial disease rather than venual involvement, but some patients can have both arterial and venual. Okay. All right. All right. So the obstructions are classified as either inflow or outflow. So these cause obstruction. It says the inflow involved the distal end of the aorta and the common internal and external iliac arteries, which are located above the inguinal ligament, whereas the outflow obstructions involve the femoral, popliteal, and tibial arteries and are below the superficial femoral artery. Okay. So then it talks about stages. Stage one, asymptomatic. Two, claudication. No claudication is present with that stage one. The brute or aneurysm may be present, but the pedal pulses are decreased or absent. Stage one. With the stage two, that claudication is muscle pain or cramping or burning that occurs with exercise and is relieved with rest. The symptoms are reproducible with exercise. The stage three, that's pain while resting, commonly awakens the patient at night. The pain is described as numbness, burning, or a toothache type pain. The pain usually occurs in the distal part of the extremity, in the toes, the arch, or the forefoot or the heel, rarely in the calf or the ankle, and the pain is relieved by placing the extremity in a dependent position, so dangly. Then you got four, necrosis and gangrene. Ulcers and blackened tissue occur on the toes, forefoot, and heel, and distinctive gangrenous odor is present. The arterial ulcers are typically found on the feet and toes. They're painful and have a punched out appearance. That's the hallmark of arterial, like a hole punch, whereas the venual is irregular. Also, the arterial is going to be drier and the venous is going to be more saturated. The venual ulcers usually appear on the lower legs and ankles, and they may be less painful and have irregular, uneven edges. That's the hallmark there. All right, then it's talks about peripheral arterial disease assessment. It says most patients initially seek attention for a classic leg pain known as intermittent claudication. Um, it's basically derived from a meaning of limp. Usually, they can walk only a certain distance before discomfort, such as cramping or burning or muscular pain, occurs and forces them to stop. But the pain will go away with rest. When the patient resumes walking, they can walk the same distance before it returns. Thus, the pain is considered reproducible. As the disease progresses, they can walk only shorter and shorter distances before the pain reoccurs, and ultimately it may occur even while at rest. The patients with inflow disease have discomfort in the lower back, the buttocks, or the thighs. If it's mild, it'll just be discomfort after walking about 2 blocks. If it's moderate, it'll be discomfort for 1 block. And if it's severe, it'll be discomfort less than 1 block with pain with rest. Patients with outflow experience burning or cramping in the calves, the ankles, the feet, the toes, on the instep or foot discomfort, which indicates an obstruction below the popliteal artery. If it's mild, they'll have discomfort after 5 blocks, moderate, discomfort after 2 blocks, and severe, they cannot even walk more than a half a block. So they need to dangle the feet at night to relieve the discomfort. So we need to palpate all the pulses in both legs and compare the strength bilaterally. This is the best indicator is posterior tibial pulse. To check the posterior tibial pulse is the best indicator. All right, so then we move into the diagnostic assessment. MRI, magnetic resonance angiography, with contrast medium, can visualize blood flow. The segmental systolic blood pressure measurement involves assessing systolic pressure at multiple points along a limb, typically the lower extremity, to evaluate blood flow and identify potential arterial obstructions. With peripheral arterial disease, with be lower than the brachial pressure, the patient needs to be supine. To detect outflow disease, they use the ankle brachial index. An ankle brachial index of less than 0.90 in either leg is diagnostic of peripheral arterial disease. Patients with diabetes are known to have a falsely elevated ankle brachial index. They can also do the plethysmography. This measures systolic blood pressure in the arms and legs using blood pressure cuffs attached to a pulse volume recorder. All right. So then we talk about interventions. Avoid vasoconstriction. So no caffeine, no nicotine, and no stress. We also have to teach them proper foot care and skin care to prevent infections and wounds, especially for those with that arterial disease. And then we can do our endovascular procedures such as angioplasty. They can inflate a balloon to widen a narrowed or blocked artery, or they could put in a stent. A small tube is placed in the artery to keep it open after angioplasty, or they may have to do an atherectomy. A specialized catheter will remove that plaque buildup in the artery, or they can do lithotripsy, where they'll use shock waves to break down calcified plaques. And then we can also use the medications, the antiplatelet agents like aspirin, clopidogrel. These can prevent blood clots and further narrowing of the arteries. Anticoagulants such as warfarin. Now, with warfarin, you gotta know, pay attention. The nurse should observe for manifestations of hemorrhage because it is an adverse side effect of warfarin, which has anticoagulant and anti inflammatory actions. We've already mentioned the HMG, CoA reductase inhibitors, or the statins. We can use those to reduce cholesterol. Um, and then you've got the silostazol and the pentoxifylline. These meds can improve walking distance and reduce the claudication symptoms. And we can advise lifestyle modifications. Exercise, a structured exercise program. It needs to be supervised. This is the cornerstone treatment of arterial disease, especially for intermittent claudication. It'll help improve blood flow and walking endurance. And also, no smoking. Get them to stop smoking, and a diet, a heart healthy diet, low in saturated fat, cholesterol, and sodium, along with managing any diabetes and maintaining a healthy weight. Okay. All right. Then it talks about aortoiliac and aortofemoral bypass procedures. This is you have graft occlusion or blockage. This is a post-operative emergency that can occur within the first 24 hours after arterial revascularization. So if this happens, you need to monitor the patient for and report severe, continuous, and aching pain. This may be the first indicator of a post-operative graft occlusion and ischemia. Many people experience a throbbing pain caused by increased blood flow to the extremity. Because this alteration in comfort is different from that of ischemic pain, be sure to assess the type of pain that is experienced. Monitor the patency of the graft by checking the extremity every 15 minutes for the first hour and then hourly for changes in color, temperature, and pulse intensity. And then compare the operative leg with the unaffected one. If the operative leg feels cold, becomes pale or ashen or cyanotic, or is decreased or absent in pulses, this is an emergency situation and we need to contact that surgeon. Okay. All right. The axillofemoral bypass is a surgical procedure where a graft is used to redirect blood flow from the arm, which is the axillary artery, to one or both legs, the femoral arteries, bypassing a blockage in the lower abdomen or pelvis. This extra anatomical bypass is often used when direct reconstruction of the blocked arteries is not possible due to complications like either an infection or high surgical risk. All right, so the acute peripheral arterial occlusion, a serious condition where blood flow to an artery in the legs or arms is blocked. This leads to a loss of oxygen and potentially life-threatening ischemia. It's often caused by a blood clot or an embolus or a severe arterial narrowing. The symptoms include pain, pallor, pulselessness, the P's, coldness, paresthesia, and potentially paralysis, the P's. Treatment involves restoring blood flow through the procedure, like clot busting medications, or an embolectomy, or a bypass surgery, or even angioplasty or stenting that we talked about earlier. And then here are those P's. Okay. Here are those P's. We got to know those P's. We should know those P's. You can cite them from the door. All right, then you got the acute peripheral arterial occlusion interventions. These include thrombolysis using clot busters, embolectomy, a surgical removal of the clot, or a bypass surgery, creating a new pathway for the blood flow around the blockage, or angioplasty and stenting, using the balloon to widen the artery and a stent to keep it open. Prompt treatment is crucial. Without treatment, the limb may be lost due to tissue death, known as gangrene. Even with treatment, there's a risk of amputation, approximately 11% in some cases, and some individuals may not survive the condition at all. Okay. Then it goes into talking about aneurysms. This is permanent localized dilation of an artery, which enlarges the artery to at least 2 times its normal diameter. And you've got different types of aneurysms. You got the fusiform. This is a diffuse dilation affecting the entire circumference of the artery. You also have saccular. This is an outpouching affecting only a distinct portion of the artery. And then you got a true aneurysm. This is the arterial wall is weakened by congenital or acquired problems, whereas a false aneurysm, this occurs as a result of vessel injury or trauma to all three layers of that arterial wall. And then you got the dissecting aneurysm. These differ from aneurysms in that they are formed when blood accumulates in the wall of an artery. Remember, and this is very, very, very important. Remember. the abdominal aortic aneurysm is the most common type of aneurysm. All right, then it just shows you those pictures there, those different types. Okay. Then it talks about aneurysms of the central arteries. A pulsation in the upper abdomen, slightly to the left of the midline between the xiphoid and the umbilicus, may be present. A detectable aneurysm is at least 5 centimeters in diameter and auscultate for a bruit over the mass, but avoid palpating the mass because it may be tender and there's a risk of rupturing it. Now, pay attention here. Pay attention. Hypovolemic shock. The nurse should anticipate an increased heart rate as an early indicator of shock because the body is attempting to compensate for the decreased circulatory volume. Gotta know that. All right. So the thoracic aortic aneurysm, a bulge or ballooning in the aorta, the main artery carrying blood from the heart within the chest. The treatment will depend on the size of the aneurysm, how fast it's growing, and the presence of symptoms. Small, slow growing aneurysms may only require regular monitoring and lifestyle changes like controlling blood pressure, quitting smoking. Larger or rapidly growing aneurysms may require surgery to repair the weak area of the aorta. Surgery can be open or a minimally invasive procedure called a thoracic endovascular aortic repair. Okay. All right. So it says aneurysms, still interventions. We can do non-surgical interventions like decrease the risk of rupture, so control the blood pressure, the hypertension, or non-surgical invasive percutaneous endovascular interventions like stents. Okay, they can also do mechanical rotational abrasive atherectomy or rotoblator. This is a percutaneous coronary intervention technique used to treat severely calcified coronary artery lesions. It uses a high-speed diamond-coated burr to grind and ablate calcified plaques, allowing for better balloon angioplasty and stent development. And it just talks about do not palpate any mass. Okay, and talks about the surgeries. All right, let me see here. The aortic dissection. All right, the aortic dissection. Okay, the aortic dissection usually occurs in the innermost layer of the aorta. The body's main artery tears, causing blood to flow between the layers of the aortic wall. This will lead to a weakening of the aorta and cause severe pain, potentially leading to rupture and death. This is caused by high blood pressure, which is the biggest risk factor, but also congenital heart defects, connective tissue disorders like Marfan syndrome, and trauma. The symptoms are going to be a sudden, excruciating, tearing pain in the chest or back. Other symptoms can be shortness of breath, loss of consciousness, and stroke like symptoms. Now, the types. Dissections are categorized as type A, which means involving the ascending aorta, or type B, the descending aorta. So above or below. That's how we remember. There's two aortas, ascending, descending, above, below. You may find the client unresponsive. So the nurse needs to check the circulatory status by palpating that carotid pulse for 5 to 10 seconds before initiating further intervention. And you got to know that. Okay. You got to know that. Palpate the carotid pulse. All right. Okay. It just tells you here what types of things you need to be assessing for the aneurysms. Okay. What you're going to note. and what to do. Interventions: put into large IVs, run to 0.9 sodium chloride, and the treatment will be based on what's all going on. Okay. Then it goes into peripheral venous disease. This is a circulation disorder that affects the veins. They're responsible for turning blood to the heart. It can cause veins to become damaged or blocked, most commonly in the arms or legs. Common types of peripheral venual disease include chronic venous insufficiency, deep vein thrombosis, and varicose veins. With the chronic venous insufficiency, this occurs when the valves in the veins don't work properly, so they don't allow the blood to flow backward and potentially causes bulging veins. With the deep vein thrombosis, a blood clot that forms in a deep vein, often in the thigh or lower leg, and symptoms of this, and we need to know this, pay attention, we need to know this. The patient will report a dull, aching calf pain. That is a sign of a deep vein thrombosis. Other manifestations are edema, warmth, and redness in the calf. Got to know that. With the varicose veins and large and sometimes painful veins that occur when blood pools. All right, with the venous thromboembolism or the DVT, this is a blood clot in a deep vein, and which can lead to a pulmonary emboli, which is a blood clot in the lung. The causes of the VTE can occur due to factors like slowed blood flow, damage to blood vessels, or underlying medical conditions. This is basically called Virchow's triad. Virchow, endothelial tissue damage, okay, hypercoagulable state, and venous stasis. So what it's saying is any trauma to the vessel, the inner lining is called the endothelial layer. So endothelial tissue damage will lead to the body releasing platelets, which will cause a hypercoagulable state. Well, the blockage of this trauma or damage to the vessel and the combination of the platelets will decrease the blood flow, which is the venous stasis. And that is called Virchow's triad. Again, endothelial tissue damage, hypercoagulable state, and venous stasis. So the VTE can occur due to factors like slowed blood flow, damage to the blood vessel, or that medical condition. Risk factors are immobility, surgery, injury, certain meds, um, medical conditions. Symptoms can include leg pain, swelling, okay, leg pain, swelling, redness, and warmth, as well as shortness of breath and chest pain because of the possible PE. The diagnostics tests like duplex ultrasound and blood tests can help detect the VTE. Treatments may include blood thinners, blood clot blusters, and compression stockings. So anticoagulants, thrombolytics. Prevention: stay active, avoiding prolonged sitting, and use those compression stockings, which can help prevent the VTE. Now, pay attention, pay attention. Got to understand this, pay attention. Heparin is an anticoagulant that stops new clots from forming. The nurse should inject the med into the abdomen above the level of the iliac crest, at least 2 inches from the umbilicus. Heparin and warfarin are both anticoagulants that decrease the clotting ability of the blood and help prevent thrombosis formation in the blood vessels. However, these meds work in different ways to achieve therapeutic coagulation and must be given together until therapeutic levels of anticoagulation can be achieved by the warfarin alone. This usually takes 1 to 5 days. When the client's PT and INR are within therapeutic range, the heparin then can be discontinued. So the nurse should teach the client safety measures. Use an electric razor to decrease the risk for injury and bleeding. All right. We talked about this. Look, here's Virchow's triad right here on this slide. Okay. All right. So then it talks about the uh, assessment, Moore's assessments, the Padua prediction score. This is meant to assess risk for VTE, not to diagnose it. During the nursing assessment, 1 point is given for each of the characteristics, which include whether they have active cancer, previous VTE, or reduced mobility. So this will determine how much of a risk they are for that VTE development. All right, it just goes further into the assessment stuff. Okay. All right, now interventions. Teach that patient leg, ankle, and foot exercises. Got to know this. Pay attention. Teach that patient leg, ankle, and foot exercises. This can help improve circulation and prevent venous stasis while the client is resting. We can step it up also and do surgical procedures for patients with recurrent DVTs or pulmonary emboli that do not respond to treatment, or for patients who cannot tolerate anticoagulation. Um, they can do an inferior vena cava filtration. The surgeon or interventional radiologist inserts a filter device into the femoral vein or jugular vein, and this will trap an emboli before they progress to the lungs. Holes in the device allow blood to pass through, without interfering with the return of the blood to the heart. Okay, so it's like a net, it catches those clots. All right, then it just goes over the foods high in potassium. Guys, yams, sweet potatoes, spinach, soybeans, broccoli, lima beans, seaweed, mushroom, avocados. Very high. All right, it's continuing to talk about that venous insufficiency. Just remember, there may be stasis, dermatitis that can result from this, reddish brown discoloration of the skin along the ankles, extending up the calf. This happens in people with long term venous insufficiency. They also develop stasis ulcers. They can result from the edema or from minor injury to the limb. The ulcers typically occur over the malleus, more often medially, so in the inner ankle, not as much on the outer ankle, more so on the inner ankle. And the ulcer usually has irregular borders. Okay. Then it just got a picture here of the differences between that arterial versus venual. Make sure you go back through that, but we talked about most all of these. Okay. Then it just talks about varicose veins, what you can do, the 3 E's: compression, hose, exercise, and elevation. And then we have this question here. It says, the nurse is caring for 4 clients with a history of hypertension. Which client will the nurse see first? Well, you got to look at, not only do all of these have problems, but some of them may have more than one. So we've got a 30-year-old with preeclampsia and a blood pressure of 120/68, a 41-year-old with chronic kidney disease, blood pressure 138/80. Then you got a 53-year-old on diuretics with a blood pressure of 160/80. So a client on diuretics that remains hypertensive requires intervention. Okay. The other ones have a blood pressure that is normal or that can be addressed after the nurse sees that client. Okay, but that client has a definitely high blood pressure and they're supposed to be on diuretics to lessen it, but they ain't working. Okay. And then our final question says, a client with hypertension asked about the cause. Which nursing response is appropriate? Okay. High cholesterol is a causative agent of essential hypertension. That should be the correct answer. All right. So that concludes what we're talking about for this week, but I would really go back over the areas that I said that you really needed to pay attention to. I kept saying, pointed it out. I mean, those are going to be really crucial. I want you to learn all of it, but you know, you need to know the rule of nines. You need to know the Parkland burn formula. You need to know burn interventions and assessments. You need to understand the thrombus and emboli. You need to know about warfarin/heparin therapy. You need to know about chest tube maintenance. You need to know about endotracheal tube maintenance and vent care. You need to know about a thoracentesis, respiratory acidosis, metabolic acidosis, review the breathing patterns, Know about hypovolemic shock, how to use a meter dose inhaler, trach suctioning, IV insertion. Um, there's a lot of things that you need to cover. Okay, so you got to study, study, study. Hopefully, hold on a minute. Hopefully, this was helpful for you, but we gotta get this. Hold on a minute. Trying to sign in here. Mm, All right. All right, I'm gonna try to give you just a little bit better to focus. Hold on a minute. Mm-hmm. All right. Again, we'll go through this one more time. Um, remember what it said in the lecture. What happens when you get a burn and you're tachycardic and you need to replace those fluids? What is the ultimate sign that those fluids are doing good? We need to know that. Okay. What type of burn do we worry about? Like, what are the more severe burns? What was it talking about? Burns to the face and burns to the chest, and also inhalation burns. So, what do we got to check for? All that kind of stuff is important. Remember the circumferential burn. Remember the fourth degree burns, that thick, hard, leathery tissue, what it can do, and what's the procedure that we do to help with that. What do you need to inspect for when you're doing your assessment? It talked about the DVT or the venous thromboembolism. What were the signs that the patient's going to report to you? What are you going to see? Okay, what are the interventions to prevent that? What do you teach them to do? If you found an unresponsive patient, what would you immediately check? Okay, what are the biggest risk factors of taking anticoagulants, antiplatelet aggregates, thrombolytics? What is the biggest risk factor? That's a no-brainer. Okay. What do you do if you have a patient that experienced a burn to the face, neck, and arms or chest, and you're worried about airway? What would you do? Of course, you're going to make sure it's patent. You're going to administer the oxygen, and you want to elevate, but you can't elevate if there's a fracture. Okay. So you can elevate if there's an fracture. Remember what you're listening for those heart tones for. What are you listening for? Okay. What is the most common type of aneurysm? Remember, we went over that. Okay. You got to know the teaching. Why would a patient be on both warfarin and heparin at the same time? And then what are the interventions you're going to have to come up with if they're on either one of these? Where do you give an injection of that low molecular weight heparin? How do you give that? Um, what would you do what are the priorities for someone on a ventilator? What are the priorities for someone on a ventilator? Remember that VAP. Remember, they can get that VAP. They're at risk for that ulcer. What do you got to do with that tube every day? And what's the minimum head elevation? You need to know that. Um, thoracentesis. What are the risk factors for thoracentesis? When you're doing a thoracentesis, you got to worry about that pneumothorax, accidentally puncturing the lung. What are your indicators that you did that? What are you going to see? What's going to happen to the patient? Make sure you know your irregular respirations and make sure you know how to say them correctly. Okay? Chain, 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 chain. Strider, strider. Um, Make sure you can recognize the sign of a bleed. What are you going to see? What is the body going to do if there's a bleed? What's the number one thing it's going to do? Make sure you understand acidosis. What system are you looking at primarily? And what's the requirement to be in acidosis? What causes you to lose your bicarb? What would cause you to lose sodium bicarb and send you into metabolic acidosis? Got to know that meter dose inhaler. How do you teach a patient to use a meter dose inhaler? How do you put in an IV? Okay. And how do you suction? You got to adjust that suction. Don them sterile gloves after you adjust the suction. Check the function of the suction catheter. Hyperoxygenate. Insert the catheter without suction. Apply suction while rotating and assess for secretion clearance. Okay. Study, study, study. Get a good grade on this one. Okay. Hit the books. Read the book. Don't just rely on this. Know how to take care of that chest tube. We talked about it. Where should there be continuous bubbling and where should there not be continuous bubbling? Where do you keep that system in relation to the patient and do those maths and do the rule of nines? You got to know the rule of nines and don't get tricked on the rule of nines. We know that the arm in total is 9%, the front is 4.5%, and the back is 4.5%. But they may say the top front. The top front. That's not 4.5%. That's half of 4.5%. They may say the top of the chest. Okay, so don't get tricked. All right, I hope everybody does good on this, and I hope this was helpful to you. Have a good weekend. Okay, and I'll see you on Monday.